All right, let's get started. I think we have a quorum. Can you all hear me through the sound system okay? Yeah? No? Okay. I think since we have such a small group in here, what we'd like to do is just some brief group introductions as well. I'll start off. My name is Caroline McCoach. I'm one of the clinical fellows here at the University of Colorado. I'm in my third year of fellowship and will hopefully be going on to faculty within the next year. And then this is, everyone knows, of course, Dr.
I can introduce myself. Hello, I'm Rossone. I'm the person who spoke earlier.
And I'm Tori Tomalia. I see several familiar faces here. I have Rossone cancer. I was diagnosed in 2013, and so I've been on crizotinib and doing some SRS for brain mets since then.
Perfect. And let's just...
Lisa Bonanno. I've been on crizotinib for 39 months and I've had a complete response. And it'll be 5 years next month when it's diagnosed.
Great.
I'm Wim Shade. I'm his husband. I'm just your support.
And I'm Luna Okada. I'm a stage 4 ROS1-driven mutation lung cancer patient who was diagnosed at the very end of 2012. I've been on crizotinib for 39 months as well, and have minor things going on. Sorry about that in relation to that, but otherwise doing well.
Jeff Wynn, ROS1, diagnosed in past December, and have been on since late December.
Great.
And Joyce.
Great.
Pamela Klein. I was diagnosed with ROS1 May of 2015, and chemo radiation stage 3B. And I've been on consecutive now for about 10 months.
Great. Great.
I'm just being stubborn.
I'm Lauren Ollie with Genentech, and I'm just here for that.
I'm Kathy Beast, and I'm also first independent advocate, supporter, and patient still.
Okay, this is my spouse, Bill. I was diagnosed in September 2012, went through standard chemo radiation, initially chemo and then chemo radiation, then crizotinib, which only worked for 14 months for me. And I'm now in a clinical trial called PF 0646392. I think there's some people in here who know it. It was called 3922. I've had brain mets and brain surgery, and I'm still here, and I had a freaky deaky lipase result of 500, which is not good, 10 times what you should have, but they're putting me back on the drug this Tuesday. For that, I'm very grateful, and I've been doing well on lorlatinib for 8.5 months now. Oh, my name is Dotsa Brennan.
Thanks.
I'm Marilyn Hino. I'm a foreigner in here. I have a HER2 mutation. I was diagnosed in 2011, and I had chemo radiation and surgery. At that time, I was stage 3, and it reappeared 6 months later in my spine, and we've been dealing with that. And I was on a maintenance. I had chemo again for that, and maintenance of Avastin for about 2 years, which I stopped in January, just to have a break from poisoning my body. And I'll have scans in another week or two and find out what's going on inside.
Okay. Thank you.
And this is my husband, Mick.
I'm the other half.
Great.
I'm Lisa Goldman. I recognize a bunch of faces. I was diagnosed stage 4 in January of 2014. I did 8 months of chemo and then switched to Xalkori, and then coming up on my 2-year anniversary on Xalkori. It's probably not real quick. And this is my husband, Edward.
I'm Eric.
I'm Bonnie Shadrack, and I just took your advice. I don't
for the foreigners.
Yeah.
I'm a foreigner. Then, yeah, we could just grab us on the break and see if we can throw some pearls of wisdom your way.
Perfect. So a little bit more of how we plan to do things. We'd love for this to be a discussion instead of a lecture. And so to that end, I have in this presentation multiple little vignettes that can be mixed and matched. They don't have to go in order. And so if the questioning and conversation leads us a different direction, we can skip forward or backward. And then also Dr. Camidge and Tori have as well some presentations that can follow as our discussion flows.
I'm fine if you'd like to call me Ross, by the way.
Right, sorry, force of habit. All right, so just some overview of what I'm going to be discussing and the vignettes that I have prepared. So I'm going to try to focus a little bit on basics and beyond. And we're going to do a little bit of taking you back to high school biology so that we can actually talk about what ROS1 is. And if this is much too basic for you, apologies, and feel free to ask more in-depth questions. There are no questions that are off limits. If I say something that is too jargony or too lingo-y, feel free to also call us out on that, and happy to explain as well. So we're going to do a little bit of lung cancer categorization, where we started, where we are now, the cell biology piece, and what actually is a fusion gene, right? Then some ROS1 background basics, as well as then some of the data for treatment with crizotinib, and then how we think about progression, the mechanisms and how they occur, as well as up-and-coming therapies for second line and beyond. And interrupt, ask questions. I do have little breakpoints in between as well. So first, lung cancer categorization. We started out thinking about lung cancer as two very broad and not very cleverly named categories of non-small cell and small cell. Non-small cell making up the much larger proportion here in blue. And then as our savvy and technology evolved, we realized that non-small cell was actually multiple different categories, and the two largest of those are adenocarcinoma and squamous cell carcinoma. The adenocarcinoma here in blue, again, making up 55% of the group. And now, in the molecular era, we have discovered that really adenocarcinoma is not just one cancer, that it is actually multiple different kinds of cancer that we can categorize based upon DNA changes that we think drive the cancer itself or make it what you've probably heard as oncogene addicted. And this is a sampling of 875 patients who all have lung adenocarcinoma, and it's looking at the different proportions of molecular driver mutations in those cancers, meaning DNA changes that we think drive those cancers, and most importantly, DNA changes that are often targetable. And so ROS1 is kind of here in the middle, and it's listed at 2%. And what is most critical to understand here is that when you're diagnosed with a lung adenocarcinoma, your work is not done diagnosing. You still need to figure out which of, if any, of these subcategories you have. So take-home points and opportunity for question is first, treatment with lung cancer has evolved with the science, and that it is really critical to identify specific genetic alterations that are treatable with targeted therapy, and that ROS1 is found here listed as 1%, and really depends on the population, but 1 to 2% of lung adenocarcinomas. Yes, sir?
If you were to take the two charts that you showed us previously and put a timeline against it, so the development and the evolution of the mindset and then subcategorization, what's the time span?
Oh, decades. Decades, absolutely. You know, erlotinib and the whole EGFR story really came about in 2004, and that was the first kind of targeted therapy, so to speak, that we think about. But this whole progression is decades long.
But if I look at so if I'm looking at the bottom right, if I'm looking at the bottom right, when did that sort of come into clearer focus, I guess literally and figuratively?
Early 2000s, late 90s. Mm-hmm.
But really, the move to saying these things exist, the move from saying these things exist to these things matter is probably within the last 5 years or so.
And I guess the third point is the first is they exist and they matter and they can be treated.
Yeah. So I'll give you an example. So, ALK had been described in the lymphoma by which it gets its name. So it stands for anaplastic lymphoma kinase back in the 1990s. And nobody cared because there was no drug. It was a footnote. And the irony is that the drug companies didn't care because it was too rare in lymphoma for them to make any money out of it, if I can speak honestly. And then in 2007, it was discovered in about 4% of lung cancer, and that 4% of lung cancer is a much bigger market. And maybe the mindset had also changed, and we had EGFR mutants. And suddenly, it was much more of a perfect storm to have an abnormality, have drugs in development. And I think ALK really helped to shift the balance because EGFR was often viewed as the exception. There was EGFR mutants and then everything else was the same and it didn't matter. And then suddenly you had a second targetable abnormality and people became hungry for the third and the fourth and the fifth example. And that's where that pie chart that Caroline showed has really started to matter as people have started to say, well, what are the drugs for those slices? And then they have continued to discover abnormalities. So, the new kids on the block. When did Bob discover the NTRAX in lung cancer? 2 years ago, 3 years ago? I mean, so they're still slowly filling in little slices of that pie, but it's really exploded over the last sort of 3 to 5 years, I'd say.
I want to follow that up with, I had genetic testing from a private lab, and they did over 400 mutations. Now, obviously, we're going to learn more of the median thing. Should a patient get repeat testing as they go further in their treatment for genetic mutations?
Well,
Did the mutations evolve?
why don't I leave that one because I think Caroline's going to cover that a little bit.
Yes, and that is a great question because we are absolutely going to touch base on that. So a little bit more into what ROS1 actually means. And this is taking us back to high school biology a little bit, and cell biology specifically. So in the upper left-hand corner, the blue thing that kind of looks like a turtle without a shell is supposed to represent a cell. Within that cell is the nucleus. The nucleus is where the genetic information that programs how the cell functions is stored. That information is stored on the DNA. And it is stored in the form of chromosomes. And you can kind of think of DNA and chromosomes like the rubber band balls that are in your junk drawer. Each rubber band is DNA, and you store them tightly wound around each other so that they're organized and not just kind of all floating around in your junk drawer getting mixed up on things. So within the DNA, you have discrete genes that are programmed into what are the bases. So the bases you can think of as these little different colored lines along here. And so the whole progress goes that you get DNA, discrete pieces of DNA have the programmed information for a gene. And then when the cell wants to make a specific protein, the gene is then turned into RNA, which is then turned into protein. And for some of you all, this may be either too basic or too complex, but at the end of the day, each cell has the information to make up to 25,000 different proteins. And those proteins all serve very different functions. Some of those functions serve in growth and proliferation of the cell. Some proteins can act as messengers. Some proteins can function within the immune system. Some can be actually for storage, and some can be structures in the protein. And really, what those proteins are and what they do depends upon the cell type you have. So each protein has a very specific function, much like you have different cars that have very specific functions. However, sometimes proteins go bad and cells go bad. And so for those of you who are more in the 80s realm, this is a Decepticon. And that's when a protein goes bad, it turns into something that causes a lot of trouble. So when we think about proteins going bad, we're going to focus on a specific kind of protein that focuses on transporting information. And that is on the cell surface. It is called a receptor. There are many different kinds of receptors on cells, and those are represented with the different colored arrows on the outside of the cell. And the red arrow represents a tyrosine kinase receptor. It's just a specific kind of receptor. And it functions in growth and proliferation of the cell. And the way it functions is that information from outside of the cell, represented in the orange, activates that receptor, which then in turn sends information into the cell to grow and divide. However, when that protein goes bad and is perturbed, what can happen is that despite not receiving a signal from the outside, it still signals the inside of the cell to keep growing and dividing, which ultimately is why there is cancer. And the receptor is now actually changed. It is a fusion protein. So how do we actually get a fusion protein? It's not two separate proteins that were created and then mushed together. It's actually a change in the DNA itself. The way that that happens is that you have your initial DNA sequence, and then somehow the DNA is basically cut. And that can occur from DNA damage, for example, radiation, radon, environmental damage, or it can be a part of natural replication where the DNA is replicating and cuts itself. At the end of the day, though, what you get is a double-stranded break, meaning that the two gray lines are cut in half. And as part of the normal cellular machinery to repair damage, the two cut ends are glued back together. But the cell is not really smart enough to know what goes together. And so if there happen to be other cuts in the DNA, it will just fuse the two closest things together. And so then what you get is actually you get DNA from gene A sewn back together with DNA from gene B. And that ultimately gets you RNA from gene A fused to RNA from gene B, which then gets you this fusion protein, which if you think back to this guy, is then how you get the tyrosine kinase receptor that is thinking that it's always on because you have this fused protein that's getting misinformation, giving misinformation, excuse me. Of course.
So if you're talking about two different genes and segments fused together,
Mm-hmm.
isn't ROS1 the name of the gene?
So,
So
great
is there
question.
another gene
Mm-hmm.
we're talking about?
Yes. So we can think of ROS1 as the red here, gene A. And then you have a partner gene, which is in black. And so when we think about the fusion genes, there are many different kinds of cancers, and I'll specifically answer your question in like 2 slides. But fusion genes occur in many different kinds of cancers. In leukemias, they actually have specific partners all the time. It's always going to be the BCR gene and the ABL1 gene that are hooked together. And in promyelocytic leukemia, it's always going to be the PML gene with that other gene. But in solid tumors, you have always a base partner with somebody else. And we're going to fast forward. So in ROS1, that somebody else can be one of many different genes. And these are, it's too small for you to read because the point was not for you to see each of these specific partners, but just to know that there are quite a few different partners that can be the fusion gene.
Are they on the same chromosome or?
Excellent question. And Yes and yes. They can be the same chromosome, or they can be a different chromosome.
Are
Yes.
they adjacent genes on the same chromosome like that?
Yeah, so what can happen? Can you hold that light?
Yes. Microphone assistant.
So what can happen is that when you get a double-stranded break on your DNA, you can think of a chromosome, and that's the center of the chromosome. And when you get a break, you essentially have a loose piece of DNA. And that loose piece of DNA can flip around, and then you can rehook right here, upside down, or that it can be a completely separate chromosome that then also has a break, and you can get this loose piece of DNA going over here. So both things can happen, and there are all kinds of different variations. Because it's a little chaotic, and the cell can really only essentially tell, oh gosh, we have DNA that has been broken. We need to hook it back together again. We're not smart enough to figure out, all right, well, this piece goes with this piece, and this piece goes with this piece, so we're just going to get everybody back together again and hope that it is semi-functional.
So even ROS1 is multiple different diseases, really.
Mm-hmm. Exactly.
Are we just not sophisticated yet enough to have, so that your diagnosis gives you these subheadings too? Or is it that all of these subheadings probably existed at once under ROS1?
So, I think your question is, has it always been that we have all of these different kinds of fusion proteins, and right now we just don't know if they're important to know who the partner is?
Yeah.
Is that?
When you get your diagnosis, why don't we have it down to this molecular level?
Like when you get lab results,
Yeah.
they'll tell you.
And that is a great question. And that comes into how we actually get the diagnosis of ROS1. And each of you who have the ROS1 mutation fusion protein in your cancer have had a testing modality of one of these categories. Your testing has either been by FISH, by immunohistochemistry, RT-PCR, or sequencing. The only way to actually identify which specific partner is connected to your fusion protein is with the sequencing, if you don't know in advance. RT-PCR can somewhat, but it is a little bit limited. Sequencing with, for example, okay, so for example, if you've had Foundation Medicine testing, that will tell you, that is with next generation sequencing, and that actually tells you who your ROS1 partner is.
But not all labs do that.
Not all labs do that, but here's the really important issue. The real question is, does it matter?
Yeah.
Because remember, the thing that's giving the signaling is the ROS1, and that's the same in everybody. Okay, that's why you're all sitting in this room. The thing that it's been attached to in order to make this fusion gene may or may not matter, and we don't know. So don't get too freaked out just this second.
But Ross, I guess that was my question, which is, so if we were to know these different types, is there the potential or the likelihood that there would be different treatments that would be more optimized?
So the analogy is with ALK. As I think, Tori, you were saying this last time, that like it's always like ALK/ROS1. You feel like you're always this kind of like country cousin which is dragged along with it. But let's turn that into a positive. Let's say, well, what have we learned from this bigger group of people? Well, in ALK, it's sometimes referred to as EML4 ALK, but that's incorrect. That is the most common fusion partner, but there's a whole bunch of other ones, and so, which is why people more experienced with it tend to refer to it as ALK fusions or ALK gene rearrangements rather than specifying a fusion partner that may or may not be there. And as far as we can tell, that fusion partner doesn't make any difference. Now, it's not an it's not a huge data set, but it doesn't seem to matter. Tori, you had a question.
Well, am I remembering correctly that it can occur in like glioblastoma and other things? But I recall seeing a chart somewhere where the different, like these are the ones that show up in lung cancer, But in those other cancers, sometimes they have different fusion partners that may
Yeah,
indicate where in the body.
There's a reason for that. Okay, so let's backtrack a wee bit. Now, I don't know enough about the natural history of ROS1. ROS1's sort of normal function is a little vague, but ALK is a little better understood. So ALK has a function when you're a little ball of cells. So it's involved in developmental processes and the formation of your gut and visual system, and then it's turned off. Okay, it has no role in, anything once you're fully formed as a fetus. It's silenced, and the bit that sort of tells the gene to start working is just silenced. So what the gene fusion does is it brings in the starter program from that other fusion partner. And the key thing is that other fusion partner has to be active in the tissue in which you've got the cancer. So it may be that the reason you might have slightly different fusion partners in brain tumors from lung cancer is because they can bring in genes which are normally expressed in brain tissue versus normally expressed in lung tissue. So it's not changing the downstream consequences of turning it into a cancer cell. It's just saying, we can only open these programs in this tissue versus that tissue.
Is there a possibility when we have more data further studying ROS1 as far as these fusions and resistance do you think it's a possibility that they'll discover that maybe having those different partners is what's going to determine why some people do respond longer to certain drugs than others?
So I think absolutely. Right now, in terms of whether the fusion partner matters, so this is data from Alice Shah's group, and whether the fusion partner matters or not, and it's actually a really quite small sample size. And so I think it is absolutely true that we may find that certain fusion partners are more responsive, maybe not. The bit that the crizotinib works on is not in the fusion partner, though. That is within the ROS1 gene itself. And so I think that as Ross was mentioning, that's important to keep in mind. But I think that overall we may find at some point that there are certain ROS1 fusion partners combinations that do have more fitness or more responsiveness. But right now,
if you look at that, I don't see a pattern. There's a range across every one of the fusion partners. The arrows presumably means they're still on drug and they haven't stopped, and presumably when there's a blunt end it stopped.
Mm-hmm.
You can see short bars and long bars in each of those groups.
yeah.
So going back to your diagram here, if you have a portion that breaks off and perhaps can flip, and then another one on a separate chromosome, could there be a translocation where they would actually switch places?
So yes, exactly. That is in effect what is happening is a translocation.
That certain other somatic mutations can cause other diseases, other primary sites, and other organs. Is it known that depending upon what translocates to it, you could be at risk for other primaries?
So I think what you're asking is if you have a translocation and a chunk of your DNA goes from one place to another on the chromosome.
Do they track those to see if those patients eventually develop another kind of cancer?
I don't know that there's been tracking of that.
I got to try and pull apart your question here. So, are you saying if there's a yin and a yang, if one fusion partner forms the ROS1, what happens to the other bit? Is that what you're saying?
That, or if from another chromosome, depending upon where the translocation came from,
Yeah.
if that fusion, that specific fusion is associated with other cancers.
Usually not. Usually what's happened, so you've taken a chunk out and moved it somewhere else. What happens with the other bit that joins together is just nothing. And don't forget, the reason it doesn't really cause other cancers is this is happening in one cell. It's not happening in every cell in your body. So you've got something that's driving your lung cancer. It's not, for example, like the BRCA mutation that some people with breast cancer have, that what that actually does is it increases their risk of developing these kind of gene rearrangements and mutations. And it just so happens that the two organ sites which are most fragile are breasts and ovaries. But if you have a prophylactic mastectomy and you have your ovaries taken out and you live long enough, then you will get cancers in other sites. You know, you're just identifying the highest risk groups that you manifest clinically, and if you get those off the table, you can get other things. The other example is there's a condition kids get, which is called retinoblastoma, which again is an inherited predisposition to getting a cancer. It doesn't mean you've got it, but it increases your risk. And as its name suggests, classically you get it in your eyes. If, this sounds slightly gross, but if you could imagine somebody who didn't have eyes, they will then develop subsequent cancers in other parts. The eyes are just the highest risk area.
I just want to make sure I heard correctly earlier. We know what the AKL's original purpose was. We don't know what the ROS1 original purpose was.
So actually, that is a very well-timed question because
We rehearsed this.
in terms of what the original purpose of the ROS1 fusion gene. So this was a gene that was initially characterized in 1984. And it was actually characterized by two separate groups at about the same time, which happens more frequently in biology than you would think. But essentially what those two groups did was that they injected different pieces of DNA from tumors into different either mouse cells or otherwise to see if they could get cancer to be triggered. And both of those two groups found the ROS1 gene. And then the normal function we think is also during very early development where it is active in kidney, intestine, and lung tissue. And if you remember back to the blue cell picture with the red arrow, supposing to depict ROS1 as a receptor on the surface of the cell, we actually don't know what activates normal ROS1 or what that lightning bolt is. That information is not known at this time. Does that cover that question? Okay. And then in terms of ROS1 fusion positive cancers, as we've already covered a little bit, we know that they're active in many different places in the body. This is a sampling of all of the different kinds of cancers in which ROS1 fusion proteins have been found. So I think as we've mentioned already, it's not specific to lung cancer. And we already covered this slide a little bit in the different testing methods that each of you all have received one of. FISH is very common. Immunohistochemistry is coming online as sort of an initial test. And then RT-PCR is not used very frequently, but does use the RNA. And then sequencing can use RNA or DNA. And then the different fusion partners that we discussed, as well as whether the fusion partner matters at this point. And I just want to take a quick break here and describe this kind of chart a little bit, because we're going to be looking at a few of these further down the line and want to make sure that we're all on the same page. But on the vertical axis is all of the rows, essentially. And each row represents a single patient. And then the bar across the horizontal axis represents how long that patient has been on treatment in months. And then the orange arrows represent that at the time that this data was published, these patients were still undergoing treatment. And when there's not an arrow, the patient typically had either progressed or switched treatment. So that is not critical to...
That's so you can tell one group moves to the next.
Yeah.
That's graphic design.
All right. So going back to Dr. Shah's initial characterization of ROS1 positive cancers and their responses to crizotinib, this is the typical patient characteristics that we see. And I'm going to touch base on two additional studies with crizotinib and ROS1 positive patients, and they have very similar demographics. So the age range, the majority of patients were diagnosed in the 50s, but you can see that there's quite a big range from the 20s to the 70s. And so really we cannot say, well, this patient is X age, so we really shouldn't test for ROS1. There is a slight female predominance, and there is a little bit of a race predominance, but it's hard to say whether that's a sampling error or not. Absolutely, though, there is a increase in never smokers having this compared to smokers, and then it is almost always in adenocarcinoma versus squamous cell carcinoma. So a little bit of take-home points and any additional questions of this section. Found in many cancers, there are multiple ways to test for ROS1. And I will also say that there are pluses and minuses to each of those ROS1 tests, and some can result in false positives and false negatives. So it's not definitive that if a test comes back, it's not ROS1 positive, and that the fusion partner may or may not impact detection of mutation or outcome. Yeah.
Ross, I think I heard you say that the fusion partner doesn't matter, at least for crizotinib, because crizotinib's working on the ROS1 piece, not on the fusion partner. But I thought I heard that, at least for the second-gen TKIs they're developing, they might be more targeted to certain fusion partners or ways people progress, or you're looking at me like I've got that all.
I mean, no, I defer to the fact that you may know something I don't know, but I haven't heard that.
Yeah, Alice Shaw found something with the partner CD74, and she saw a secondary mutation of, I believe, G203 that looks like it has a impact on resistance and patients eventually failing on crizotinib and needing to go on another targeted therapy or hopefully future immunotherapy.
But I think that mutation is still in the ROS1 domain. Is that what you're going to draw?
Yep. Yes, sir.
So it's not relevant. So when
I got my foundation medicine report back, they go CD74 ROS1.
Yes.
Mm-hmm.
So is that misleading?
No, that's accurate. So because that's a sequencing assay that describes what your fusion partner is. That resistance mutation, though, isn't occurring in the CD74. It's occurring in the ROS1 bit.
Okay, that's why I was wondering where that was affected.
Yeah. Because the resistance is the resistance of where the drug binds,
Right.
and the drug binds in the ROS1 bit. But anyway, Caroline's the expert on that.
Right, that's what I was wondering was where the mutation is.
Absolutely, and we're going to touch base a little bit more specifically on that, but just as a very rough depiction, what you have is that you have the fusion protein, which you can think of as the black arrow from the cell picture. And then the red arrow you have here is the ROS1. And in my drawing, the protein looks something like that. In fact, it is very much more organized and very complex. But what happens ultimately is there's sort of the business portion of ROS1 where it actually allows for the signaling of downstream information. And the most important portion of the business part of ROS1 is called the tyrosine kinase domain. And that is made up of multiple amino acids, which you can think of amino acids as sort of a subgroup of protein. So you have DNA that goes into RNA, which is then made into a protein, and the sort of base pair portion of a protein is called an amino acid. And that is where you actually get this G2023 mutation. So when you had your next generation sequencing, that is part of the beauty of doing such defined sequencing, because you can see that there will be a mutation here or here or here, that can make it such that crizotinib no longer is able to bind to this area and block information from being transmitted into the cell for the cell to grow and divide. And so that information from the next-gen sequencing is essentially what tells you, well, this is why crizotinib may or may not longer be working. No, this is in the cell. And so this is outside of the cell. And then this is in the cell in the cytoplasm. And then the nucleus is kind of over here.
Are you getting a new mutation that's causing this? Is that
Exactly. Exactly. So you can kind of think of it as when you take an antibiotic and then all of a sudden your cold starts coming, or your flu starts, or whatever starts coming back. It's because you've developed resistance to it. It's sort of akin to that, is that you've been on this drug and now you've developed a new mutation, and the cells that have that mutation are no longer sensitive to crizotinib, and so then your cells that have that mutation start growing and growing and growing.
So the new mutation is still associated with ROS1.
Absolutely.
It might be just a new fusion partner.
It's not a new fusion partner. It's the same fusion partner, but it's a mutation within the ROS1 portion of that fusion partner. So a little bit, we're going to backtrack a little bit to some of the original data for crizotinib and its efficacy in ROS1. So we've all probably seen dramatic images like this of how well crizotinib can work to shrink lung cancers. And that ROS1 in and of itself had, or crizotinib rather, showed a really impressive response rate to ROS1 cancers. And so this, just to orient us a little bit, what we call a waterfall plot for those of you who are not super familiar with it. And in this plot, each column is a single patient. And what it's measuring is the percent change from baseline, so the percent change from when the patient started crizotinib, which is right here. And so you can have up to a 100% change, meaning that the patient have had a complete response to treatment, and all of the measurable lesions that they were following for the trial and beyond are 100% gone. And then you have decreasing down to 0%, and then a couple patients who had disease progression over in the blue. Now, in terms of clinical trials, when we say complete response, we mean no evidence of cancer is present on imaging. When we say partial response, that's anywhere from basically 99% decrease in tumor down to 30% decrease in tumor. And then stable disease is anywhere from 0 to 30% change in the tumor. And so that's just sort of categories that are used in clinical trials speak, okay? And then time on treatment before progression. So this is the swimmer's plot where each row represents a single patient. And this is the data for Shah et al. I think we kind of covered this before, but essentially the progression-free survival in this group of patients was 19.2 months. Now, the second study that we're going to talk about is the UROS-1 study. And the difference with this study and the Shah study is that in UROS-1, they actually did this retrospectively, meaning that they went back through after the fact and did chart reviews to look in a European cohort of patients, a European group of patients, to see how they responded to crizotinib compared to the clinical trial patients, to see what the real world, quote unquote, experience was. And in this group, you can see here, so each column represents a patient, and they absolutely had some patients with great responses. These numbers here at the bottom represent the number of prior therapies that these patients received. And so some of the patients had had not that much treatment, and then some had had I think 5, 6, 9 prior therapies before receiving crizotinib. And so you can see that here the distribution is very similar, and the response rate that they reported in their study was 80%. Absolutely.
Does this come up with any information relevant to sequencing? Because we've been wondering whether, just from looking at stories around the table, whether it makes any difference whether you hit it with chemo first and then move to Xalkori versus going straight to Xalkori.
And that's a great question. I don't know if that specific study has been done, and I think what I'm understanding is you're wondering in terms of treatment sequencing whether it's better to have Xalkori first and then go to chemo and that provides longer, or vice versa.
Well, I think here's our data. So, no, I can't. I'm squinting too, but again, there's a lot of people who this is first line treatment. There's ones who are either getting moderate response or great response. Again, let's draw an analogy with all of the caveats about analogies. When EGFR mutants first came out, the response rate and benefit was no different if you got it in the first line or if you got it after chemotherapy. And the rationale behind it is the cancer is made up of a mixed population of cells which are similar but different, and they evolve, their makeup adapts to the current environment. And when you treat them with chemotherapy, what survives is what's resistant to the chemotherapy. But there's no similarity between sensitivity to chemotherapy and sensitivity to a completely different thing, a ROS1 inhibitor. And therefore, training the cancer to be resistant to chemotherapy has zero impact on its ability to be sensitive or resistant to the crizotinib. And so my guess is it probably doesn't make a lot of difference. Now, you might feel a bit more beaten up. There may be some knock-on effect in terms of the overall fitness of people. But I suspect almost, for many other oncogene-targeted subtypes, they've done studies of targeted therapy versus first-line chemotherapy, and the targeted therapy always wins. The fact that we have, 9 of you in the room or whatever it is, there's never going to be enough ROS1 patients to do that study. And to be honest, after they'd done, I don't know how many studies they did in EGFR, at some point people went, can we just stop doing those studies? We know the answer. So if you're diagnosed with ROS1, I think you should go on the targeted therapy first. If you're diagnosed after you've already had chemotherapy, that's just the way it is. If you're already on chemotherapy when the result comes back, I'd probably finish the chemotherapy and then play it second rather than deny any benefit from the chemo.
And so an interesting piece of information from the UROS-1 retrospective study is that these patients actually had a median progression-free survival of 9.1 months, which, if you remember, is about 10 months shorter than in the prior study. And I think that the question is, why so much shorter? And we have to remember that in the Shah study, that was a clinical trial in which patients had to be of a certain performance status. So they had to be quite healthy, and the performance status cutoff is 0 to 1, which is really a fairly healthy person. Whereas this, because it was retrospective, they weren't really able to assess patients' performance status. And many of the patients had multiple prior treatments and showed progression pretty quickly and probably already pretty beat up from the trial.
Well, there's another explanation. So if you look at the little blue arrows, as I count them, I don't know, there's something like 22 patients there, and 18 of them have still got the little blue arrows.
Right, and then
So
they
it's an immature data
published
set.
earlier as well. But still, I think that if you're reviewing the literature and seeing that, that's important to keep in mind that there are multiple explanations for a report of a shorter progression-free survival.
Does the previous slide have any influence on this slide? You know what I'm saying? Meaning that the percent of response, does that influence?
Yes, so that is something that we are actively looking at in terms of, well, are these people down here on the waterfall plot going to be the same people as the people who, on the swimmer's plot, make it all the way across the ocean. And our suspicion is that it is, we actually published or presented an abstract at ASCO this year that looked in ALK, so as well as in immunotherapy, at whether the people who had the best responses to therapy were also the people who did the best. And we did see that there was a trend toward that.
When you say best, you mean longest?
Mm-hmm.
And you don't know.
Well, I mean, I think just in terms of, as you're thinking about, well, you have the biggest decrease in tumor burden, and so it's going to take the longest for those cells to develop additional mutations, and just thinking about evolution of the cancer is our speculation. I mean, we don't have a specific answer. Yes?
I want to talk about performance status.
Yes.
I mean, do we know what performance status requirements were for Shah study versus this study?
Absolutely. So the Shah study, the performance status requirement was an ECOG score of 0 to 1. So really fairly healthy individuals. In this study, they did not report on performance status, which is, in addition to kind of reporting the data fairly early, can be one of the explanations for why many of the patients kind of came off a little bit sooner as well.
Just a question on when you talk about a response, is that measured in a PET scan, an SUV, or is it just measured in the size of a tumor? I mean, is it?
No, that's
sometimes it's hard to see if it.
No, that's a great question. And so the question is, how do we measure response in a clinical trial? And right now, we typically use the CT scan as the measurement of response. And we have your baseline measurement, and then with each successive CT scan, we measure either a shrinkage or increase in growth of specific lesions that we designate in advance, so before you start the trial. And what is coming down the line, though, is that eventually we may use a combination of the CT scan and PET scan SUV. We may also begin to use volumetric studies, so kind of the three-dimensional measurement instead of just the two-dimensional measurement. So.
Why don't we go for another 5 minutes before we have a break?
Okay, so we'll just cover a little bit more. This is the East Asian population study of crizotinib, and this is actually the largest study that has been done so far on crizotinib. It was 127 patients, and in this study, you can see that the results were much more similar to the Shah study, and that the performance status, which I don't show here, or excuse me, the progression-free survival, which I don't show here, was 13.4 months in this study, and so much more similar to the Shah data.
Can you just explain what a median is? Because that progression-free survival is a median.
Yes, so you have mean, which is the same thing as an average. So you add up the average number, you add up all of the months that each patient went on the trial and then took the average of those months. The median is if you basically just keep marching in from each extreme and you get that middle point. And so what the median, using that instead of mean as your point of reference, helps is if you have huge outliers. So if you have a really great responder who has been on for 80 months, and that's not really representative of everyone else on the trial, then that helps to, using the median instead of the mean, balances that out.
And the same for people who have 2 weeks on the drug.
Yes.
They kind of trim the extremes.
And what was it, 13?
I think it was 13.4 months. And also, I believe all these slides are going to be available online, and I have the references down in the lower right-hand corner, or left-hand corner rather, and so you can kind of copy and Google paste those as well.
I think, why don't we, because
This is a good break
we're
point.
about to go into what happens when the crizotinib stops working. but why don't we just have like a 15-minute break so that you can recharge your brains?
And let's do a photo. Yeah. Before you disappear, let's do a quick photo.